Hello. I'm audible, right?
Yes, sir, you are audible. Screen, what is visible is that Dr. Biswarup has started screen sharing. The presentation is not still visible.
Presentation is not there. Okay. But is okay. Sharing. So, hi. Good morning, good afternoon, based on the geographies that you are in. The topic today is very relevant to the general practice all over the world, which is vascular disease from the GP's office to the specialist clinic. There will be a name of a few brands of medicine throughout this presentation, but there are no disclosures. These are just worldwide available medicines, which helps kind of create a uniform platform for connecting. So, coming to the first slide is what are the common diseases that GP's clinic might encounter? So, the most common are peripheral arterial disease, hypertension-related vascular disease, aneurysms, and acute arterial occlusion. The acute arterial occlusion is something that immediately needs to be sent to the nearest emergency department. The rest three can be very easily managed by the general practitioners in a very reasonable and rational way and then be sent across to us. Uh, oh goodness, that's how it works. Okay. Next slide, venous disorders. So almost always varicose veins, deep vein thrombosis, chronic venous insufficiency, and superficial thrombophlebitis. So these are the three or four common conditions that would, be commonly seen by a general practitioner or a surgical practice in their day-to-day life. So the first thing is how should you refer a suspected arterial disease? Get a viral serology, get a creatinine clearance, and get a peripheral CT angiogram done right at the point where you've encountered arterial disease. Directly tell us, the problem that the person is facing. At times, there are GP clinics that are smart enough to, even send in requests like it's got peripheral arterial disease, acute occlusion, needs embolectomy. So, the interventions are at times suggested, though we believe that we are a better judge of it. But if something comes to you from a GP clinic with a reasonable, clarity, it also helps us do a lot of things in terms of our international patients, kind of suggest the cost, as other things. But always remember that the first thing you send is always an imaging for most of the diseases today. If you're sending me a coronary, I want a coronary angiogram. If you're sending me a cancer, I want the chest CT. If you're sending me a vascular disease, I would want the echocardiogram. If you're sending me a vascular, I would want the peripheral CT angiogram. So more often than not, the story starts with the image, and more often than not, the story normally in real life practice starts with an ill-scribed prescription with biochemical values of the patient's sodium, potassium, last cholesterol levels. Those may be important, but not when you are referring a case. So in referring a case, the first thing is always the image. I mean, almost always in every disease that is presented to us commonly, it is first the image. So if you're suspecting a peripheral arterial disease, leg pain, occlusion in the lower limb arteries, some atherosclerotic changes, the first thing you should do is get a viral serology, get a creatinine clearance, and do a CT peripheral angio. You will need the viral serology and the creatinine to put the patient through the peripheral angiogram where he will be injected the dyes. The viral serology will also more often than not give you an idea of if there is a viral etiology. There are, it is not unusual to have viral etiology presenting as an aneurysm. Creatinine, yes, will give you a rough idea of how the kidneys are functioning and whether you can, inject reasonable amount of dye for procuring an image. And then you get the CT angio. The CT angio at times is so suggestive that you could directly send us a request with the patient detail and the NGO asking for like a embolectomy, asking for a bypass grafting, asking for something that you feel is reasonable and rational to the patient. And always remember that when you're suspecting an arterial disease and you do not have an arterial cause, do not leave it there. Do suspect a neurogenic pain. Do follow it up with either imaging the lower back or doing tests like the nerve conduction velocity test. So always do them, separate them, and then send them across to us because I'm currently in the middle of managing a patient which Mr. Varun might be knowing in her post-operative phase with 95% pain resolution without any vascular intervention. So we need to at times understand when to intervene and more importantly when not to intervene. Uh, Coming to the next pair. So I mean this is one of my favorite reads, all-time favorite reads is a Nobel-winning author called Gabriel Garcia Marquez, who writes in his book The Loving the Time of Color. The scalpel is the first failure of the proof, the first proof of the failure of medicine. So yes, if it is a peripheral arterial disease, there are multiple medical options that you have. You would have pentoxifylline for arterial narrowing, where you can use them as peripheral arterial dilator. You would have silostazole, where you can use them for squeezing out the RBCs through the narrowed arteries. And then when it comes to the presenting complaint, which is pain, you always have amitriptyline or any tricyclic antidepressant at a reasonable dose, which is not too debilitating with the daily activities, but gets them reasonably off the pain and a good quality sleep at night. So the surgical avenues for a peripheral arterial disease can be multi-pronged, starting from peripheral embolectomies with the Fogarty catheter to moving on to peripheral arterial, open repairs. To today, in the age of stenting, we are reasonably engaged in endovascular work and we stent everything, starting from the aortic arch down to the aortic bifurcation, down to the peripheral artery. So we are basically into stenting uh, every single artery in the body. I mean, I'm not my practice does not kind of allow me to stent coronaries, so I'm not doing it like the cardiologists should do. But apart from it, for all the other vascular work would largely be done by cardiologists in this country, which is not quite indicated. So today, the vascular surgeon has stepped up his role. He's got into the endovascular zone. We are doing more often than ever before all the peripheral stenting, and with amazing results because we are by training surgical specialists. So we would be doing this hand-on thing much better than other people, right? So multiple surgical options for people with arterial disease, and it always helps if the surgical person or the vascular surgeon is involved in choosing which one to be done. This is one of the hybrid operating rooms where I have personally worked. This should be the hybrid operating room at the Auckland Hospital, a place that was kind of home for me for a couple of years. And this is the Auckland DHB hybrid operating room. So a lot of our current operating is also hybrid, where we take the help of image intensifiers and the gantry to kind of get entry into the vessels, use low ionic contrast dyes, and kind of manage problems that would otherwise require a major vascular operation and a long protracted recovery just in moments. Moving on from the arterial disease, if we go back in time, so we've basically covered peripheral arterial disease, hypertension related vascular disease. We have not so covered aneurysms. So for aneurysms, whether it is abdominal, whether it is the thoracic aorta, or whether it is in the femoral artery or down below, same thing. The most critical intervention that you can do as general physician is get a CT peripheral angiogram, and that will tell us with no uncertainty as to what we exactly need to do. Sending me a report which says infrarenal abdominal aortic aneurysm or a suprarenal abdominal aortic aneurysm does not make much sense to me. The image makes sense to me because the image
Dr.
my
Biswarup,
landing. Yeah.
my request to go a little slow, sir, because
Oh,
at
I'm
times
so sorry.
very fast.
So coming to aneurysms, always send us the image. There will be a report. It's an infrarenal abdominal aortic aneurysm. Makes no sense to a vascular surgeon. A single image makes all the sense. It tells me my landing zones. It tells me my maximal diameters. It tells me my preferred modality that I would want to do. And occasionally, not unfounded, is a report with a recommendation. I mean, it is basically equal to insult. A report of image with a recommendation that such and such, and more often than not, these recommendations would come from the developing world with very fancy recommendations. TAVI for a huge dilated aortic root with aneurysm, TEVAR for a subclavian that is occluded, and endovascular repair for suprarenal abdominal aortic aneurysm without a chimney stent. So do make a basic recommendation, but nothing very fancy. Remember that at times old is gold. The time tested open repairs are at times the modality of choice, even today. Aneurysms make sense only when there are two things: either there is a catheterization data or there is a CT imaging. The report of the CT image is only for those that are going to make or break a decision because they don't read their own CT scans. Get very confident in sharing the DICOM files with the healthcare facilitators, because Jivo, for one I know, has a very robust system where they share all the imagings with us in the DICOM format, and we can really go back in real time, see them in our softwares, reconstruct them, 3D images out of them, and that kind of gives us uh, a very good ground where we can tell you the exact thing the patient needs. Because an open abdominal aneurysm repair vis-a-vis stent graft repair, the price difference would be something around $40,000, 40,000 US dollars. An open repair would be to the tune of 10 to 15,000 US dollars. Uh, Interventional repair would be somewhere to the tune of 45 to 50,000 US dollars, because the graft itself would be around 30,000 US dollars. So rather than suggesting fancy interventions because the chat GPT or the AI says so, or because, so do share an image for anything. Acute arterial occlusion, don't share anything, just send the patient to the next ED, the next emergency room next to you. That's not a clinic thing. Venous disorder, I'll basically be covering varicose veins, deep vein thrombosis, chronic venous insufficiency, and superficial thrombophlebitis. Hmm. Okay. So whenever talking of varicose vein in today's time, we are not talking about mild, moderate, severe. We are straightforward talking about the CP classification, which classifies the varicose veins from C0 to C6. And if I'm referred a patient, or if I'm told that this is basically a C1 or a C2 CAP class varicose vein, I would more often than not even not want to see the patient in clinic, just ask for a couple of photographs and based on that give you some non-invasive stockings or medications, for your use. Though that saves the patient an entire trip to a different country just to get a non-invasive treatment. Always, always, always get a Doppler done with three things. With the patient standing, with the patient lying down, and with the patient lying down and doing a Valsalva maneuver. So this same Valsalva maneuver might make a saphenofemoral joint regurgitant that was otherwise, quite non-regurgitant, normal looking, normal dimension. The moment you increase the afterload and the moment you do a Valsalva, that joint might, start leaking, and that gives you an idea that there is an SFG regurgitation. Once you've asked for a Doppler, kindly ask them to look for the SFG regurgitation, the perforator size, report it as a CAP grade, and do advise them to wear some form of compression stockinets more often than not if it is an identified varicose vein problem before sending to us. Because by the time you send to us, the CAP class might have reduced by one. She might have turned from a C3 to a C2. And remember another thing, never ever dismiss a varicose vein as cellulitis of the leg. This is the most common, mistake that we make in clinical medicine is branding every other swelling in the leg as either a uh, cellulitis, or some form of chronic venous insufficiency. It could be an acute DVT. This would be my next thing, that how do you diagnose DVT? So for DVT, remember that you should have a very high index of suspicion, and you need to confirm this suspicion with an imaging. The answer for DVT is not D-dimer. The answer for DVT is imaging. The answer for DVT is anticoagulation to treat the DVT. Whenever you feel is a likely DVT, the first thing you do is you do an ultrasound scan within the first 4 hours. And depending on if the ultrasound scan is positive, it is diagnosed. If the ultrasound scan is negative, it is then only we do a D-dimer. A positive D-dimer in the absence of an ultrasound may indicate a DVT, but every sane mind would ask you to repeat the scan in about 6 to 8 days' time, because that is necessary. Any sole and leg, do not dismiss it as a cellulitis with some antibiotics and pain relief. Do investigate it at least minimum with the ultrasound scan or a Doppler scan of the lower limb veins, deep veins, just to see and rule out any potential DVT. So why am I so against D-dimer? So I say whether it is D-dimer or D-day. The biggest disadvantages of D-dimer is a low specificity and an extremely high false positivity. There are half a zillion things, from smoking to exercising to having fever to having an infection in the body, that can give you a high D-dimer. It is, yes, quicker. It has no radiation. And well, if the D-dimer is positive, then it might indicate a multitude of things. Whereas if the D-dimer is negative, it can potentially effectively rule out DVT. But remember, D-dimer is a high sensitivity, low specificity test. It is no longer worldwide the first test for suspected D-vein low specificity. It has high false positive rates, and there are half a zillion things in this world which can turn the D-dimer positive. So suspicion of deep vein thrombosis is a very common referral we get. In today's time and age, with point of care ultrasound, DVT is not a supposed, it is a definite diagnosis. Always, if you are imaging somebody for DVT with the ultrasound scan, do complete the scanning regimen with the CT pulmonary angiogram, because as you can, I'm so sorry, as you can see here. So this is a central occlusion of the pulmonary artery right at the bifurcation of the main pulmonary into the right and left pulmonary artery. And these thrombuses are classically called as saddle thrombus, much resembles the saddle of a horse. Where the same different patient with the CTPA now shows a branch emboli. You can see this dark area. So these are basically the branch emboli and not a saddle embolus, which has gone on to separately block the right and left pulmonary artery. There are multitudes of devices and other interventional procedures that you can do. The best of them probably is the inari flow retriever, which will go in, engage with the pulmonary emboli, lock them into a ADO-occluder disc mechanism, and pull it out part with the help of um, kind of ablating the clot into smaller pieces, piecemeal, and then sucking them out with adequate suction. And the gold standard for any pulmonary embolism the world over remains this surgery, which is basically the pulmonary endarterectomy. So pulmonary endarterectomy is basically going on bypass and what is so this is basically going on bypass, stopping the, yeah. Hello, am I
Hello.
audible?
Yes, sir, you're audible. I think it was accidental. Dr.
Okay,
Bills, trying to say something.
We are hearing you.
Okay, Dr. Biswarup, this that was accidental.
okay. So pulmonary endarterectomy remains the gold standard surgery for pulmonary endarterectomy for pulmonary embolism. So we stop the heart, we go down to very low temperatures of 18 to 20 degrees centigrade for the body. We stop the body circulation, the brain circulation for somewhere around half an hour to 45 minutes, and we take these massive clots out of the body, out of the pulmonary system. The lungs kind of get back to absolute normal, the pulmonary pressures come down, the right heart function improves dramatically. In a couple of days, it would have improved after surgery. And today, I mean, I have trained with one of the biggest names in pulmonary endarterectomy in this country while he was still awake, Dr. P.V. Rao and Dr. Devi Prashant Sethi. So, I mean, they had one of the today in the recent STS guideline on pulmonary endarterectomy, their institute, our institute, finds a special mention as the largest center for pulmonary endarterectomy anywhere outside the United States. So, having trained at such a high volume center which specializes in pulmonary endarterectomy, I always tell that though a bit morbid, though a major undertaking, a pulmonary endarterectomy remains the gold standard choice. And especially for a center like us that does a lot of mechanical circulatory support and are okay to support the patient postoperatively with an ECMO, pulmonary endarterectomy is the absolute gold standard surgery for any saddle, branch, any pulmonary embolism. Coming to the deep vein thrombosis, always remember that when you have diagnosed a deep vein thrombosis in the absence of pulmonary embolism, the first thing to do is to start them on anticoagulant therapy. Today, more often than not, we are starting on them on the newer anticoagulants rather than the tried or time tested, warfarin and low molecular weight heparin. So rivaroxaban, out of the few drugs that are available, has emerged as the drug of choice. Whether it is a deep vein thrombosis or a pulmonary embolism complicated from a deep vein thrombosis, the first line of treatment is 15 milligram of rivaroxaban twice a day. The best part is that it does not need any renal dose adjustment. Um, if it is a slightly older a patient which is older problem which is presenting to you maybe after the first 3 to 4 weeks of developing a DVT, then you probably start with 20 milligram of rivaroxaban once a day. The same also does not affect your kidney or is irrespectively of your EGFR or GFR ratio. And also it has become as a very favored agent for those that undergo debilitating surgeries and need to be bedbound for a very long period of time, something like hip or knee replacement surgeries in the orthopedic department. So they benefit a lot from the rivaroxaban therapy. Though the common or the more prescribed drug out of rivaroxaban and apixaban is Eliquis, which is the apixaban tablet. But you always need to remember these ABCDs of apixaban adjustment. Anybody who is more than 80 years of age, whose body weight is less than 60 kg, whose creatinine is more than 1.5 milligram per deciliter, these will double the risk of using apixaban without dose adjustment, and we need to halve the dose from 5 milligram twice a day to 2.5 milligram twice a day, or even once a day, depending on how bad your creatinine is or how bad your how cachectic you are, how low body weight you are. Uh, Coming to the last of the venous complication, which is basically superficial thrombophlebitis, it is the most common problem that we encounter in slightly overweight females in their 40s. uh, and they would have these extremely dilated looking veins, but they're actually inflamed veins, the thrombophlebitis. So the treatment is very simple: rest the limb, elevate the limb, ice compress the limb, which is the traditional RICE, and apply ointments like thrombophob or hydroid, one of these, which either contain heparinase or contains a very local form of hydrogen which is taken from the leech, and the same can be used to just you know get on top of this thrombophlebitis and get them better, get the pain lesser. I think that will finish the common complications of the problems that is seen in a GP clinic, and the house will now be open for question and answer.
Uh, uh, Thanks, Dr. Biswarup. In your presentation, you included one case that we encountered with you.
Yeah.
I mean, initially it appeared to be, that arterial disease. And there was arterial disease, but the pain,
Correct.
the judgment, and even but while you had suspected, and further investigations here and management plan indicated that it was not vascular disease pain,
It is a vascular disease, but the
and
vascular problem is not what is causing the pain.
yeah.
And for an elderly lady, if you don't need to intervene and only medicines can manage, then you don't need to intervene. Even if it means losing a patient, losing a potentially, a commercially win-win decision to a commercially lose-lose decision, I'm happy to make the decision every single day of my life because the trust that was put on me, it is very silently there has been a transition from the doctor-patient relationship to the doctor-hospital relationship. When I was in medicine in my early days, I understood it to be a privileged communication where your data, your condition stayed safe with me. Today it has become your data is not my data. Your data is the hospital data. Tomorrow I change a hospital, all my patients' data cease to exist with me, stays with the hospital, potentially stored in servers, exploited by the data analysts. So the privilege is fast fading. Then there'll be some old school people like me who will resist these changes. But more often than not, the more data we see, at times it may not be great. So at times, yes, the old school way of approaching a problem, the old school way of respecting the trust, operating only when needed and never when not needed. So this thing will be the
Dr.
cornerstone
Biswarup,
of
that this
medicine.
case was a very interesting because in past also we encountered, and I want to highlight a case that a patient had presented with pain in the eyes. It prima facie it appeared to be ophthalmology intervention. On investigations, the problem was revealed to be something in the brain, like a neurosurgical one. So many a times in medicine, we see that prima facie it may appear to be something like you also highlighted in your talk about. I'm forgetting the word that not to confuse those varicose veins with other
Yeah,
presentations.
I said never confuse a varicose vein with the cellulitis and give them
Cellulitis, yeah.
a bout of antibiotic and just drive them away. I mean that's the wrongest possible thing. And these are problems that happen in real life GP clinics. I mean these are not constructed scenarios. You know.
And so you had also pointed out like whenever a doctor shares a patient history with another doctor, the need for relevant medical information and notes, because those were shared with you, you were able to like suspect that the problem lies elsewhere, not in a vascular intervention, and of course the risk, etc. So if you can, and you highlighted this, so
I've
other doctor colleagues,
on
they
her daughter today afternoon. I mean, while I was rounding in the hospital, half an hour before we spoke on the phone, I actually spoke to the lady, and I think she's recovering well.
yeah, yeah. No, so what I want to say is that, like, now let's keep the patient aside for a minute. Like, it is about collaboration. Like, there are so many doctor colleagues, and in
Yeah.
fact, we have Dr. Daniel Okitundu. He is professor of neurology, neuropsychopathology in University of Kinshasa. Like 35 years of teaching experience, the old school, like you were suggesting. So we
Yeah.
have, I mean, such personalities here. So basically, sir, the thing that I want you to double down on, like you are a specialist here, you receive reports. Other than Jivo, you receive reports from a lot of
Oh,
sources.
yeah, absolutely.
So how important it is, like to put the interpretation head away, but share the
It
accurate
is,
medical information with
it
the
is very
specialist
important
medical.
because I would, me being me, I would not say that only Jivo does it. Maybe one or two companies, but if I am engaged with say 25 odd healthcare facilitators, only one or two of them would send a report in a structured format. Only about yesterday, I had to very gently reprimand somebody who sent a report apparently with a very different name, suggesting a male with a different age, and then another report with a female name and saying that the name went wrong the first time. the gender went wrong the first time, so we thought, okay, gender wrong, might be a different patient. Then we, at the end of a half a day struggle, understood that they are trying to give us two reports to the same patient in different formats. One is in a PDF, the other is a broken image. There is no PowerPoint, so there is no collated PDFs, one you can open and go through. And that makes it very difficult. That makes it very difficult for you to explain yourself, for me to understand myself. And I'm happy to, not give
No, no,
somebody the wrong piece
but
of
but
advice or the wrong information which has not been properly collated. So it often happens that if the information is not properly tabulated, you tend to give a wrong advice to the right patient.
no, no, sir. But fortunately, in Jivo's case, whenever there's a referral, the reports, I mean, the here credit goes to our doctor partners because they share the reports. Once we collate, because we may make mistakes, they review it for accuracy and the
Right.
sequence of presentation, and then that's when it is shared with you. Because I want to highlight, like a few days back, I was just browsing through how others in this cross-border care, how they present their information, and I identified one case. I will share the screenshot. I can share the screenshot later with you, but I don't want to share the name because we don't want to defame anybody. So those people have listed as a success story of a successful prostate cancer treatment in a female. And I was like, females don't have prostate. How
Right.
can there be a success story, a testimonial around successful prostate cancer? And they have listed Fortis as the hospital that treated it. Like, I don't know if it is highlighted to Fortis people, how are they going to react? Like, so this is what middlemen and agent do. That's why we are creating this forum so that doctors, like let's say Dr. like Darius, Dr. Daniel, or Dr. Innocent, they can directly interact with specialists like you and identify what's the right path for their for the patient.
Right. So open for questions if
Yes,
any of
sir.
the doctors.
There is a question from Dr. Ivan. Now, Dr. Ivan is from Uganda, if I
Yeah,
remember the country correctly. Yeah. So he is thanking you. Can a patient with DVT have a normal D dimer?
absolutely.
He wants you to explain, little bit explain.
So I mean, the thing is, if not done on time or if done after the acute phase of DVT, when you have a DVT that has set in, maybe for a few days, he's not presented right on the day of the pain, tried some trickery at home, some over the medicines. Despite the high sensitivity, the patient can go on to your clinic with a DVT in a few hundreds, not thousands, or even a DVT maybe which is say, 150 or 200. Not good enough for you to have diagnosed a DVT on the basis of it. It's a very simple presumption that we got to make. If it is a DVT, it is an anatomical problem. And for every anatomical problem, the option is to see the problem. Say, you're seated at home and your friend who's out in the yard on a Sunday says, oh, there's a beautiful rainbow in the sky. Unless you have a very different personality, you would definitely not want to hear prose on the beauty of the rainbow, but rather just go out and see the rainbow yourself. So the same for anatomical problems. If there is a deep vein thrombosis, I want to see it. I want to see it on an ultrasound. I want to understand. And ultrasound is such an easy tool. It took me barely 3 to 4 months to pick up a standard ultrasound procedure, how we do it. And despite the fact that India's got a lot of challenges in terms of doing ultrasound for the, as per the Gender Determination Act in the country, we still train almost all our trainees into doing routine vascular ultrasounds so that they can identify these problems on their own. A D-dimer for a subacute DVT can just be normal, despite the high sensitivity, and you will miss the deep vein thrombosis. So I have stopped diagnosing DVTs with deep vein thrombosis. Now, you want to diagnose a DVT, you get a CT pulmonary angiogram with a kind of shoot that goes onto the legs and delayed leg imaging. Do that. If you want to identify, get an ultrasound scan done. If you want to identify, maintain a very high index of suspicion. But D dimer alone cannot be the whole and soul idea of identifying a DVT. If you go to the DVT pathway today, so the well score at the very initial stages would say that if you are suspecting a DVT, you get an ultrasound within 4 hours. They do not say get a D dimer within 4 hours. That is positive. You just diagnose DVT and start anticoagulating. You don't even need D dimer. Only when it is negative that a D dimer positivity might indicate that, well, this person potentially has a deep venous thrombosis. If a D dimer is negative, we might consider DVT, unlikely and consider other diagnoses, but if it is a subacute DVT which is presented after a few days, the D dimer might be negative. And without an expert hand, they might also miss the deep vein thrombosis, which they will kind of potentially treat the partial recanalization as a not a deep vein thrombosis. Okay, there's another question. What are the key prognosis factors of endovascular laser ablation? So, I mean, I have, the questions are validating my point. So, laser ablation for superficial, spider veins or for one or two perforator is good. Laser ablation is good till the perforator level, but if your SFJ is regurgitant, then more often than not, I would want to open a small segment into the SFJ and ligate all the four veins that drain there, right? So endovascular laser ablation, I do on a routine basis. I've only done one maybe 2 3 days back. The patient was discharged yesterday. So endovascular laser ablation for perforators, for superficial veins has an excellent progress. Even if you have only superficial navy and not no leaky perforators, I would say endovascular laser ablation might be the way forward to go. Dr. Innocent.
So we're looking forward to more questions to make it more participative. And if you have a patient case to discuss, you can discuss with
Yes,
Dr.
please
Bisu.
do.
Dr. Bisu, I had a question that
Yeah,
we discussed, and I thought, I mean, because today's topic being vascular surgery, so this is the pertinent forum to share it with larger audience. So, like in case of a 78-year-old elderly patient with indicative arterial disease in the below knee thing, and some doctors suggesting angioplasty, which according to top vascular surgeons is
I,
that
I would
nothing
I would
nothing
say
needs
if
to be done and it may need a
yeah,
risk.
I would say an infrageniculated angioplasty is best avoided, has reasonable short-term results, but nothing very promising long-term. If you are to intervene below the knee, it is more often than not a surgical intervention. If you want to create a bypass, it is more often than not a reverse FNS vein bypass rather than any artificial graft. So below the knee, try to do the simpler, older, easier things. Try to use a vein to create a bypass. Try to do or favor an open surgery more than a this thing. So that is the way forward. I mean, that is how I would look at it. Yeah.
Yes. I think today evening the room is very quiet. Otherwise, our doctor rooms are very engaging. So I request, please ask your questions. Let's make the discussion more engaging. Dr. William
I think
Gadaga.
people did not like the idea of not doing D-dimers. That's
Okay.
okay.
That could be.
I can live with
Dr.
that.
Iman, any follow-up questions? Dr. Innocent? Dr. William?
Are they in the meeting still?
Yeah, yeah, they are.
Are they in the meeting?
Right. So, if there are no questions, then we can conclude the session. Sir, if we have your permission or
Yes.
unless
Thank you so much. Thanks for
and
listening.
and
And whether I have struck a chord or not, I'm unsure. But we definitely need to move out of the D-dimer business for DVT.